I also had the privilege of discussing three interesting abstracts at this meeting, all related to MRD assessment in multiple myeloma. The first is from Dr. Pug and colleagues from Salamanca, Spain, looking at results from the GEM-CESAR study. GEM-CESAR is a phase 2 trial for patients with high-risk smoldering myeloma. This is about 90 patients who were treated with induction therapy using carfilzomib, lenalidomide, dexamethasone, followed by consolidation with melphalan autologous transplant, followed by 2 additional cycles of carfilzomib, lenalidomide, dexamethasone as consolidation, and then all patients received maintenance with lenalidomide and dexamethasone. So the study was a phase 2 study with the primary objective of achieving MRD negativity in patients with high-risk smoldering myeloma. And spoiler alert, the study met its primary endpoint of MRD negativity at the end of consolidation, with more than 40% of patients being MRD negative using flow cytometry. Now, in the context of this study, Dr. Pug and colleagues also looked for MRD assessment using flow cytometry in comparison to response assessment using mass spectrometry. So mass spectrometry is a serum-based testing to identify monoclonal proteins in the blood, and other studies have shown that this is a more sensitive way of looking for monoclonal proteins compared to conventional electrophoresis and immunofixation. And there's an interest in the field to use mass spectrometry-based testing for MRD assessment as well. It has the advantage of being blood-based, so don't need to do invasive bone marrow biopsy procedures. It also has the advantage that mass spectrometry could capture. One of the concerns with bone marrow-based testing is that bone marrow involvement could be patchy, or if patients have extramedullary disease, that may not be captured in bone marrow-based testing. Blood-based testing could potentially overcome these limitations. So if you had a very sensitive, very specific blood-based test, it could be quite a good option for MRD assessment. And so in the context of the GEM-CESAR study, Dr. Pug and colleagues looked for mass spec versus MRD testing by flow cytometry. And what they show here is that mass spectrometry-based testing in the blood is more sensitive compared to conventional immunofixation. And given the higher sensitivity and the promising negative predictive value, their study would suggest that this can certainly be a standard option for blood-based monitoring of patients. Not quite sure we're at a place where we can replace bone marrow biopsies for MRD assessments based on this data, but perhaps it could be complementary to bone marrow-based testing, and future studies should hopefully incorporate mass spectrometry-based serum assessments in addition to the conventional blood testing and conventional serum testing and bone marrow-based testing. A related abstract was from Dr. Derman and colleagues. So this was in newly diagnosed myeloma patients. Again, a phase 2 study of patients treated with carfilzomib, lenalidomide, and dexamethasone induction, followed by transplant, followed then by about 13 cycles of carfilzomib, lenalidomide, dexamethasone consolidation. And again, all patients were also treated with maintenance with lenalidomide. Again, in the context of this study, the investigators looked for both bone marrow-based MRD testing using next-generation sequencing, as well as blood-based testing using mass spectrometry. And interestingly, what they show is that the concordance between the two tests, that is MRD testing by mass spec and MRD testing in the bone marrow by next-generation sequencing, had only a modest concordance with a kappa statistic of less than 0.4. And most of the discrepancy comes from patients who were MRD positive by mass spec, but negative by next-generation sequencing. Now, this raises two questions. One is this related to mass spectrometry in the blood being more sensitive, which is certainly possible? Or is there a higher rate of false positive testing in the mass spectrometry? We know that the half-life of IgG and IgA particularly are long, and therefore it's possible that patients could have persistent positivity with mass spectrometry even in the absence of active disease. So that's something I think future studies will need to tease out. What proportion of these discordant results are truly discordant because mass spectrometry is more sensitive? And what proportion of this is related to false positives because of long half-life of IgG and IgA immunoglobulins in the blood? Both mass spectrometry-based testing in the blood and next-generation sequencing-based testing in the bone marrow are informative in terms of progression-free survival. That is, patients who were MRD negative, but by either of these tests were more likely to be progression-free compared to patients who were MRD positive by both testing. And if you looked at the subset of patients who had discordant results, that is, patients who were MRD negative by flow cytometry, but MRD positive by light chain mass spectrometry, again, the light chain mass spectrometry based MRD testing had more predictive or was more predictive of progression-free survival compared to patients who were MRD positive by mass spectrometry. So I guess this is a small study, so there's caveats to drawing broad conclusions from small studies, but regardless, I think this is provocative in that it suggests that mass spectrometry-based MRD testing in the blood is perhaps as sensitive or more sensitive than bone marrow-based testing. And mass spectrometry positivity can predict conversion from MRD negative to MRD positive in the bone marrow in at least some patients in this study. And mass spectrometry negativity was associated with superior progression-free survival, even among patients who are MRD negative by next-generation sequencing in the bone marrow. And the small sample size will obviously need to be replicated in larger studies, but provides useful information as we incorporate blood-based MRD testing to our routine care in the near future. And the last abstract in this group was from Dr. Mohan and colleagues from University of Arkansas, a very large retrospective cohort of patients who were treated in Arkansas using intensive induction and consolidation. And all patients had flow cytometry-based MRD assessments done between 2014 and 2019. And there was a total of 606 patients in this cohort who were MRD negative after during this time point. And the intent of the study was to follow up patients who are MRD negative to see what the MRD kinetics looks like over long-term follow-up. And in their study, about 60% of patients had sustained MRD negativity. That is, at long follow-up, they remained MRD negative. And about 40% of patients had loss of MRD negativity or MRD conversion. That is, at some period in follow-up, they changed from MRD negative status to MRD positive status using 8-color flow cytometry. And what the authors show is that MRD conversion is associated with an increased risk of clinical progression with a relative risk of about 3.5. And MRD negative relapses are uncommon. That is, most patients will go from MRD negative to MRD positive before progressing. Only about less than 4% of patients progress from MRD negative status to clinical progression. What they also showed here is that both the event-free survival and the overall survival was better for patients with sustained MRD negativity compared to those that had conversion to MRD positive status. So the key message here is that with extended follow-up, MRD conversion is a relatively common phenomenon in patients who are MRD negative after initial treatment, with about 40% of patients having an MRD conversion in this cohort. The event-free survival and overall survival is very, very notable for those patients who had sustained MRD negativity in this study. I guess the limitations are that this is a single-center institution. Some of the treatments that they used are more intensive than conventional myeloma therapy, so it remains to be seen whether these results can be extrapolated to the larger cohort of patients we see in our clinic. But nonetheless, this is very important data that suggests that achieving MRD negativity and sustaining it is perhaps an important milestone, and future studies that incorporate MRD assessments to prospective clinical trials are ongoing, and more are needed to answer these questions.